Good afternoon, everyone. Happy July. We are pleased to welcome Dr. Saini here today to talk about urinary incontinence in women. Newton-Wellesley Medical Group, Lunch and Learn, Thursday right before a nice holiday weekend. I hope everyone is planning something fun. We'll move along. Let's see, we wanted to tease upcoming Lunch and Learns. Next week, we have Your Role in Data Integrity by Leah Blackstone. We're excited about that talk. We definitely receive a lot of questions from our patients about the record and how to alter the record. And then following that, we have a vascular surgery topic by Dr. Kwolek. And then following that, we have new guidelines for lung cancer screening by Sean Lear. So we're excited about our July schedule. You know, our talks are up on YouTube, and they also can be seen up on our intranet. And they also are available for self-study credits at 0.5 hours. We also want to just remind folks, our Newton-Wellesley Orthopedic walk-in is open and will be open 7 days a week, Monday to Friday, 8 to 8, and then Saturday and Sunday for any injuries on the ball field or any injuries that need to be dealt with. We have x-ray right on site, bracing and casting right on site, as well as orthopedic physician assistants and surgeons there. So please give us a call or have your patients walk on in. There's the number, 219-1280. And that again is at our 978 Worcester Street facility. Our physician wellness programs, we've been talking about on a weekly basis, our concierge program, our weekly virtual meditation and yoga classes, online coaching and physical training, and of course, our Peloton 1-year free membership. These programs with the contacts are here. Just a quick word about the concierge. So on the concierge, we have over 130 active users now, and an average savings of over 4 hours saved per request that is made. The concierge requests can be anything from getting help with people fixing your house, to picking the perfect gift, to finding the perfect restaurant, finding the best set of flowers, who's going to mow my lawn, et cetera, et cetera. This is free. Please sign up, community.circles.com. Use the code word NWH, free to all APPs and physicians. And just look at some requests that people have had. Et cetera. I want to leave time for our talk. It is a robust website. Look at all the things that people have, Father's Day gift guide, other things as well. And we can get this information out to anyone, but again, it's free. Go ahead and sign up for that. And I will turn it over. Don't forget to unmute yourself and go ahead.
Okay. Hi, everyone. So I just want to introduce myself. My name is Joy Saini. I'm a urogynecologist. I'm board certified in OBGYN and female pelvic medicine and reconstructive surgery. I completed my training in OBGYN at Weill Cornell University Medical Center in New York City. And I did my fellowship in urogynecology at NYU Medical Center. Less than 2 years ago, about 4 months before COVID, I started my own practice. It's located at 62 Walnut Street in Wellesley. I'm part of Newton-Wellesley Hospital PHO, and I perform surgeries at Newton-Wellesley Hospital, and I am now welcoming new patients. So next slide. So I have no disclosures. Next slide. So today, my goal is for you to leave with a solid understanding of urinary incontinence in women. I'm going to talk about the epidemiology of urinary incontinence, the different types of urinary incontinence, how to evaluate and manage these patients, and know when to refer out. Next slide. So urinary incontinence is a common problem. It impacts 20 million women in the United States. That's more than the number of women with diabetes. That's more than the number of women with asthma. 1 out of 4 women have urinary incontinence. The majority of these women never seek treatment, and more than half believe that there are no effective treatments. Next slide. The economic impact is tremendous. The total estimated direct cost of urinary incontinence is $19 billion. The single largest cost item for this is the routine care and supplies needed to take care of this condition. And interestingly, less than 8% of the total cost is related to just the evaluation and treatment. Next slide. So urinary incontinence is a quality of life issue, and you're going to have to click a couple of times. It affects a woman socially, resulting in isolation. Physically, it limits a woman's activities, not letting her being able to do things she normally enjoys, like hiking, running, dancing, or exercising. Sexually, It can result in avoidance and interpersonal problems. Psychologically, it can result in depression, lack of self-esteem. Occupationally, it decreases productivity, and it can also affect social hygiene. Next slide, personal hygiene. So urinary incontinence is under-recognized and treated. Just like I said, less than 50% of women with urinary incontinence consult healthcare providers, and the reasons given for this are embarrassment, the easy availability of absorbent pads, low expectation of benefit from treatment, lack of information, and many think it's a normal part of aging. Because urinary incontinence can be a difficult topic to discuss, primary care providers should screen for these symptoms and consider making it a routine part of history taking. So the risk factors for urinary incontinence include sex. Being a woman makes you 2 times more likely to suffer from urinary incontinence than a man. Multiparity, obesity, age. 1 out of 3 women over the age of 75 have urinary incontinence. And urinary incontinence is a major factor leading to institutionalization of the elderly, especially in patients with dementia. Next slide. So there are basically 2 types of incontinence that we need to be able to distinguish. One is stress incontinence, and just like it sounds, it's the involuntary leakage of urine with any effort or physical exertion, such as cough, sneezing, or exercise. The other type is overactive bladder, which is defined by the International Continence Society as urinary urgency, that strong desire to void, with or without urgent continence, usually accompanied by urinary frequency and nocturia in the absence of a urinary tract infection or other obvious pathology, where urinary frequency is defined as urinating more than 8 times during the day, and nocturia is defined as voiding more than once a night. And then detrusor overactivity is the demonstration of involuntary contractions that you see on urodynamic testing during filling. Next slide. So again, there are basically 2 types of incontinence, stress and overactive bladder, and then there's mixed incontinence, which is a combination of stress and overactive bladder. The most common type is stress incontinence, which makes up about 49%, followed by mixed and then urge. Stress incontinence, there are 2 types. One is due to hypermobile urethra. The other is intrinsic sphincter deficiency, also known as ISD. And overactive bladder, the most common type is idiopathic. And then there's neurogenic, which is due to neurological conditions. And then mixed is the combination of the 2. Next slide. So let's talk about the pathophysiology of stress incontinence. For urethral hypermobility, what's happening is that the urethra is getting displaced during sudden increases in abdominal pressure, and this occurs due to lack of support of the endopelvic fascia of the anterior vaginal wall. This usually occurs due to damage from childbirth, resulting in multiple tears, and then thereby causing this lack of support. The other type, which is actually more distressing, where patients complain of constant leakage just from slight movement, is intrinsic sphincter deficiency. And there, the damage is at the level of the urethra itself, where the urethra is unable to generate enough outlet resistance to keep the urethra closed at rest or with minimal physical activity. And this can usually be diagnosed on urodynamic testing. If you suspect that a patient has this, this is a reason for referral. Next slide. So what happens when patients have this sudden urgency and urge incontinence is that the bladder is having involuntary contractions of the detrusor muscle. There's several theories proposed for this, why this happens. There are basically 3 mechanisms. One is that there's increased sensory activity level of the urothelium or the lining of the bladder. The other is the myogenic theory, which asserts that there's increased excitability of the smooth muscle cells of the bladder. And then neurogenic theory, which there is an aberrant CNS activity occurring. There are possibly new and abnormal bladder reflexes. And the other theory is that it's a combination of these three ideas. Next slide. So let's see what happens in action on urodynamics with detrusor overactivity or overactive bladder. You can actually see in this slide, as the patient's bladder is getting filled on the 3rd row, I don't know if I can show this to you, where there's a green line, you can actually see uninhibited detrusor contractions occurring, multiple ones, as the bladder is slowly filled. And at one point, the patient just starts to leak urine, which you can see on the 6th line where she starts leaking urine. and has completely emptied her bladder. But in you and me, that line should be a straight, solid line, and there should be no contractions until our bladder is completely full, and then we void. Next slide. So the diagnosis of stress incontinence, overactive bladder can easily be made by a good history and physical examination in your office and some simple office diagnostic tests, such as the UACNS and post-void residual, which can be done in your office. Other adjuncts that can be used are a voiding diary and validated questionnaires. You don't need urodynamics or cystoscopy in the initial workup or evaluation of incontinence. Next slide. So in your history, in order to make a diagnosis, really you just want to ask some few questions. The basic question to ask is, are you having leakage of urine that you can't control? If so, are you leaking with cough and sneezing? Or are you having the other type where you're having a strong urge and on the way you're leaking the gotta go leakage? It's really important, I think, to assess the severity of this problem by asking them, are they leaking drops or large amounts? Are they leaking once or twice a week versus once a month, or is it occurring every day? Are they using any protection, panty liners versus thick pads versus pull-ups that they're using constantly? The other issue, one of the things that you want to ask is how it's affecting their quality of life. Are they unable to sleep, unable to exercise? Do they always have to know where the toilet is when they go out? Are they doing toilet mapping? So these are all questions to ask. Next slide. With regards to history, in medical history, you really want to focus on neurological conditions that could be precipitating urinary incontinence. You also want to look at their OB history of forceps, vaginal deliveries, hours and second stage of labor. Surgical history, I really think it's important to ask if they've had a prior anti-incontinence procedure, because overactive bladder is a known risk factor after mid-urethral sling surgery, with de novo OAB occurring between 15 to 29% of patients within 1 to 3 months after surgery. Next slide. So part of the evaluation or exam is an abdominal exam, making sure that there's no masses that could be contributing to the symptoms, like a large fibroid uterus. And a neurological exam, really one of the main things is to confirm the spinal segments S2, 3, 4 are intact. And the way to do that would be to do easily an anal reflex test, where you just basically touch the skin next to the anal opening with a cotton swab, and this should result in involuntary anal contraction. On pelvic exam, you want to assess for vaginal atrophy, checking for loss of rugae, whether the tissue is pale and thin, easily friable, a lot of erythema. You want to check for pelvic organ prolapse, any bulge. And on a bimanual exam, you want to assess levator ani strength, which is kind of important in terms of treatment. And the way you can do that is during a digital exam, asking the patient to squeeze the vagina around your fingers as if they're trying to prevent urine from coming out, and then rating that on a scale of 0 to 5. This is really helpful in terms of monitoring treatment for stress incontinence. Next slide. Some office tests that need to be done are a urinalysis to rule out a urinary tract infection and to rule out microscopic hematuria. You also want to get a post-void residual to make sure they're emptying well and not having urinary retention. And you can also do a cough stress in the office, asking the patient to come with a full bladder. This can be done with a patient in the supine position with just this Valsalva or a cough. And if you don't elicit stress incontinence, you can have them stand to see if you can see it. Next slide. So other helpful tests that you can use are a voiding diary, which you ask the patient to fill out for 2 to 3 days. I think this is really helpful when you're not sure about the diagnosis, or if the patient gives you vague or conflicting answers. This is really helpful because it documents everything that the patient's doing in a 24-hour period, how much they're drinking, how often they're voiding, the voided volumes, the voiding pattern can be looked at. You also have them record the leakage episodes and what activity they're doing when they leak. Another thing you can use is the pelvic floor distress inventory, and this is really helpful for looking at symptom severity and response to treatment. Next slide. Reversible causes that you should, in your mind, kind of rule out when you're evaluating patients for urinary incontinence include UTI, vaginal atrophy, which we talked about, and medications, pharmaceuticals. There's a number of medications that can contribute to stress incontinence and urge incontinence. The other thing to look at is whether they're restricted in their mobility. A lot of times patients are in wheelchairs and are unable to make it to the bathroom on time. A lot of times these patients are probably having overflow incontinence, and it would be helpful if they had a bedside commode. Next slide. So this is a listing of all the medications that can cause urinary incontinence in different ways. And I guess I would like to focus on some of them that you might see in your practice often, such as alpha adrenergic blockers that can result in stress incontinence. One study showed that almost half of female subjects taking an alpha blocker reported urinary incontinence. Cholinesterase inhibitors that we use in the treatment of dementia increase in acetylcholine, and this can cause urge incontinence. And then SSRIs or antidepressants can increase cholinergic transmission as well and result in urge urinary incontinence in about 60 out of 1,000 elderly. Next slide. So when to refer. If at this point you're not sure regarding the diagnosis, this is a good time to refer, or if you're not sure regarding the plan for treatment. If the patient has microscopic hematuria or insensible incontinence, or not even sure when they're leaking, and presence of comorbid conditions such as recurrent UTI, previous anti-incontinence surgery, bladder pain syndrome, symptomatic pelvic organ prolapse, abnormal PVR, or neurologic condition. Next slide. So how do we treat stress incontinence? Really, the treatment begins with pelvic floor muscle treatment or training. And in this slide, you can see in the top photograph, there's like a muscle that wraps around the urethra, the vagina, and the rectum, and that's the levator ani muscle. And by strengthening this muscle, you're going to help with control of urinary incontinence as well as bowel control. So I usually start my patients on pelvic floor PT for stress urinary incontinence and give them instructions on how to do it at home. I usually tell them to do at least, to do this daily, 20 repetitions twice a day. And I give them a handout on this and explain to them that it's going to take at least 6 to 8 weeks before you're going to see any improvement. Now, if the patient is not able to do this at home or is unable to contract the pelvic floor muscles, then this is a reason to refer for pelvic floor PT, where the pelvic floor PT, the physical therapist can offer biofeedback, electrical stimulation, and other things to help them work on strengthening their pelvic floor. You can also offer them at the same time continence devices such as pessaries, and there's something called poison pressa, which is like a tampon that you place in the vagina. And basically the way these work is they constrict the urethra. The poison pressa comes in 3 sizes. I've had mixed results with this. Some patients really like this, especially if they're only having mild stress incontinence. And the pessary is really useful for athletes who seem to only leak when they go running, and it really works very well. If you think that the patient has IST, that's a reason for referral because that usually involves more invasive therapies. Next slide. So this is an algorithm that's outlined here by the American Urologic Association. And basically this is the algorithm used for the treatment of overactive bladder. Again, diagnosis is made with a good history and physical, UA and PVR. And the first line treatment is behavioral treatment, followed by second line treatment, which is pharmacotherapy. You can usually start with just behavioral treatment. And I think that that's the best way to go because a lot of these patients don't want to be on medications, and a lot of these medications have side effects. Sometimes if the patient's having severe incontinence, I sometimes go straight to pharmacotherapy after discussing all the risks and benefits with the patient. If behavioral treatment and pharmacotherapy don't work, then that's a reason for referral for third line therapies, which include Botox, percutaneous tibial nerve stimulation, and sacral neuromodulation. Next slide. So this is just going over what behavioral treatment you can offer to your patient. I always begin with lifestyle modification because a lot of times I find that patients are drinking like 100 to 120 ounces a day and complaining of urinary frequency. So the first step is really knowing how much they're drinking and what they're drinking. I try to encourage them to drink anywhere between 48 to 64 ounces a day. and to avoid dietary bladder irritants that will make their urgency frequency worse, such as caffeine, carbonated beverages, acidic drinks, and alcohol. Weight loss is important in patients that are overweight or obese. There are studies to show that just a mean weight loss of 8% will result in a 47% decrease in number of weekly leakage episodes. So just starting with lifestyle modification can really help these symptoms. Also, patients who smoke, I really think that if you want to treat that problem, they have to quit smoking. You can give them all the medication in the world, but if they're smoking, they're going to continue to have overactive bladder. All these patients with OAB are treated with pelvic floor PT. Unfortunately, it requires a patient that is motivated and willing to do the work. And sometimes this does not happen. So this is such a great way of strengthening the pelvic floor in terms of treating this problem, but a lot of patients aren't willing to do pelvic floor PT. With overactive bladder, you also need to offer them bladder training because part of their problems is that feeling of that urgency and wanting to void frequently. And by reviewing their diary, you can start a program of timed voiding and progressively increasing the interval between voids. And this also is in coordination with pelvic floor PT, where the pelvic floor physical therapist can work on training them on urge suppression techniques, which are helpful in bladder training. Next slide. So as you all know, estrogen receptors are found in the bladder, urethra, vagina, and pelvic floor, and estrogen deficiency has been implicated in the etiology of lower urinary tract symptoms. A meta-analysis of 14 randomized controlled trials in postmenopausal women showed that vaginal estrogen was associated with improved incontinence. So I begin all of my patients who present with OAB and vaginal atrophy on vaginal estrogen as a first step along with behavioral treatment. And oftentimes just doing that alone, they have significant improvement in their symptoms. Next slide. So pharmacotherapy, there are basically two agents available for the treatment of overactive bladder. One is antimuscarinic agents, and the way they work is they block acetylcholine from binding to the muscarinic receptors in the smooth muscle of the bladder and preventing the bladder from having contractions. And then there's beta-3 agonists, and the only agent we have is mirabegron, and the way that works is it stimulates the beta-3 receptors of the smooth muscle of the bladder and causes it to relax. In terms of efficacy, they're both probably very similar in efficacy, and the data shows that in terms of improvement, you're going to have about a 60% cure or improvement in symptoms. Systematic reviews note that they're relatively similar in efficacy, and using pharmacotherapy and behavioral training, you're going to have better outcomes if you do both. Next slide. So this is a big, busy slide, but I just wanted to review with you what antimuscarinics are available for the treatment of overactive bladder. There's 6 antimuscarinics, and they all vary in terms of their side effect profile, but most of them have the same side effects, which include dry mouth and constipation. The reason for this is muscarinic receptors are also located in the GI tract, in the salivary glands, in your eyes. The absolute contraindication for anticholinergics is closed angle glaucoma, urinary retention, and bowel obstruction. And the point I want to make from this slide is that if you look here, you'll see that treating them, for example, with oxybutynin using the patch, transdermal, or gel is going to have less side effects versus immediate release or extended release, and there's a big difference. Also, out of this list, my favorite would be trospium for elderly patients because it's a quaternary ammonium and it doesn't cross the blood-brain barrier. So there's less likelihood, although it still penetrates the CNS, of cognitive side effects. And with mirabegron, which is the beta-3 agonist, there's 2 dosages available, 25 and 50 milligrams. The absolute contraindication for that is uncontrolled hypertension. And the side effects for that are not so bad. It's really well tolerated. I do have the patients return for a blood pressure check because your blood pressure can go up by 1 to 3 millimeters of mercury. So those are the options available. And I guess the other point I want to make is that Extended release formulations are preferred over the immediate release. I start with the lowest dose, have them come back to see how they tolerate it, and then move forward from there. The other thing is they will have side effects of dry mouth and constipation. It's important to manage those before you just abandon therapy completely. Next slide. So for antimuscarinics, again, I just want to stress that there's no single agent that's considered superior to others in terms of efficacy. There is an association with cognitive decline, dementia, Alzheimer's, particularly in elderly women over the age of 65 over 3 years of use. They're also associated with increased risk of falls and fractures in older patients. And there is a high discontinuation rates because of the side effects and the efficacy not being so 100%. And again, if I was going to choose in my elderly patients, I would use trospium or darafenacin because of the less CNS penetration. Next slide. So this is a very busy slide, but the point I wanted to make was that we just had a consensus statement come out by the American Urogynecology Society this year in February 2021, stating that the use of anticholinergic medications to treat OAB in women older than 70 should be avoided. So again, I'm just pointing out that the antimuscarinics are fine to use on younger patients less than 65, and I'd just be cautious in use in women over the age of 65. Next slide. So this is just sort of a summary slide for you in terms of management of urinary incontinence in women. You're going to see 3 things, either stress, overactive bladder, or mixed incontinence. If a patient has stress, you're going to start off with conservative management with pelvic floor muscle therapy. You can also offer them vaginal pessaries or inserts. If that doesn't work, then that's a reason to refer for more advanced therapies. With regards to overactive bladder, again, behavioral treatment and pharmacotherapy, and a combination of the two. And then with mixed, you would treat whichever predominant type prevails. Next slide. So if you've tried behavioral treatment and an antimuscarinic and the patient is still having symptoms, that would be a reason for referral. And similarly for stress incontinence in patients who have done pelvic floor PT and are still having symptoms, that would be a reason to referral. Next slide. So in summary, urinary incontinence is a highly prevalent and distressing condition in women. Primary care providers should feel comfortable making a diagnosis and treating stress urinary incontinence, overactive bladder, and mixed incontinence. And I'm happy to answer any questions.
Joy, thank you so much. That was a great review of stress incontinence and overactive bladder. I think it's something that is really helpful, at least for me as a PCP, to try to give us a framework of that. And then I just want to remind folks who might have signed on late, Dr. Saini is right on Walnut Street. She is definitely taking new patients and operates here right at Newton-Wellesley Hospital. So we want to make sure you know that her services are available. Joy, I guess I don't see any questions in the box. The one question I did have, do you ever add mirabegron to the other agents that you use as double therapy, or you move right on to other treatments if they're not working?
No, that's a great question. There have been studies looking at combination therapy, and it's shown to be, they do have a synergistic effect. So yes, I do add mirabegron if an antimuscarinic's not working. And it is really, the thing is that it's well tolerated and patients don't have increase in side effects from doing that.
And I noticed, you know, you put surgery on your algorithm at the end. I imagine a significant portion of patients, by the time you see them, end up with some kind of surgical procedure. Can you ballpark that, or you tend to keep people on the medication side or physical therapy side?
Again, it depends on the degree of incontinence. It depends on how much it's affecting their quality of life. And if it's something that's preventing them from doing things that they would normally do, and it's on a daily basis, then I lean towards proceeding directly to surgery. And
most of those surgeries are outpatient surgeries, I know, right? In and out pretty easily.
Right, they're outpatient surgeries. If they just have stress incontinence, the gold standard procedure for treatment of stress incontinence is a mid-urethral sling procedure, although there are new things coming out, such as something called Bulkamed, which can be done in the office for stress incontinence.
Well, maybe we can have you come back to walk us through some of those procedures. I definitely field a lot of questions in the office, and then people hear the word mesh and they want to run in a different direction a lot of times as well. So maybe we'll have you come back in the fall to talk about some of those procedures that you do. Thanks again. She is in the book. We can certainly get her number out, and certainly her website, bostonpelvic.com, has all her contact information. I hope everyone has a great July 4th, and we'll see you next week to talk about medical records and electronic information. Thanks, Dr. Saini. Appreciate you
Thank
giving
you so
us
much.
my
Thanks.
pleasure. Bye.
Bye.